I know it's hard to believe, but once I was young, or younger, but not so bright. And this is my ID badge from my time in Cambridge, working at Adam Brooks and working at the Brain Repair Centre, with my mentor and guest for today, Professor Roger Barker. And so it's fair to say that along your career, there are people who can see something in you that you can't see yourself, and are able to hopefully harness that and direct it in a way that you probably didn't realize you were capable of. And Roger was that person who kicked start my career. So if you like what I do, you can congratulate him. If you hate what I do, you can go and stone him later. But effectively, he's been very, very important. And I think just to close, the final thing I'd say, Roger, before I invite you to speak, is that if there was a final yearbook that Roger had composed for his past students, my entry would read, least likely student to ever go on and do research. But I'm here and I'm doing this research because Roger gave me that opportunity. I'm doing that research because what motivates me is what's sitting in front of me. Our patients, their families, and also our students who make me want to do more and more every day. With that, I'm going to pause and just say thank you for listening to me, but most importantly, now get the opportunity to listen to a real expert. Roger Barker is at the University of Cambridge. As you know, he's written a few books. He actually started writing his textbooks when he was a medical student, believe it or not. Neuroscience at a Glance. Go check it out. It's an amazing book. Had an incredible career as a junior doctor, and thankfully we managed to snag him into neurology. And for reasons that I'm not quite sure he may explain to us over coffee, he really got into Parkinson's and a disease called Huntington's, which he's not going to cover today, but has particular interests in novel ways to try and understand those diseases and treat those diseases and ultimately, hopefully, cure those diseases to improve the quality of life for people living with this disease. So please can I ask you to join me in welcoming Professor Roger Barker.
Thank you very much. The screen's been tapped. That's important.
Yes.
Well, thank you very much. And thank you very much for all coming today. What I thought I would do in this talk is take you through where Parkinson's has come in this century. Take a slightly bigger perspective, because I think, you know, Simon's touched on a lot of things, and I will touch on things that Simon's done with myself over the years with the research. But I think there's often a perception that things aren't moving, and that things, if they do move, move very slowly. And that can be the case, but actually reflecting on this talk for 25 years of what's happened in Parkinson's, you realise that things have moved quite dramatically and they're moving very fast. So you've heard a lot about it already from Simon, about how trials, which used to be quite rare, have now become commonplace. Research in Parkinson's used to be done by a few, it's now done by a lot more. So there's a real momentum with this disease. And what I'm going to do is I'm just going to pick up on a few topics and sort of hopefully explain how the field has moved and the speed with which it's moved. And these are only just a selection of things, but I thought it might be helpful for you to sort of think about some of these aspects of it. And this picture I quite like because it brings together, I think, all the elements we need in order to solve the problem of Parkinson's. So I'm not quite sure how I'm going to do this because my arms aren't long enough to reach both screens. But what I'll perhaps point at this one. So this building here in Cambridge, so this is a picture of the Adam Brooks Biomedical Campus. That building there is called the Laboratory of Molecular Biology. So that is the most successful research institute in the world. So that institute has over the years produced 12 Nobel Prizes and has 16 Nobel laureates within it. So they discovered DNA, they've discovered all of that. So that is basic science. This building here is what Simon's very interested in his team. That's Papworth, and that does sleep studies. So now we have the capacity to take basic science and to look at non-neurological problems as they would be seen. It gets more difficult, but that building there is the R&D for AstraZeneca. So industry, in order if you want to move any of this to make a successful therapy, you've got to have industry involvement. And in the years gone by, that was not seen as something you should do as an academic. So, and right here, which you can scarcely see, is the Addenbrooke's Hospital itself. So to be successful, you need to have crackerjack basic scientists who can talk to the hospital neurologists, who can work with industry, who can work across disciplines in the hospital. And that is the direction of travel. You have it here, and it's the sort of area we should definitely be concentrating on. So what I'm going to talk about are four things. I'm going to talk about, which Simon's already talked to some extent. One is how the definition of Parkinson's disease has changed and what that actually means. The second is I'm going to talk about simple facts about Parkinson's. So before this century, it was not known how common this condition is. So people often ask me, is it getting more common? We don't really know because nobody had really done the studies in the past to say how common it was. Genetics, what genes are associated with Parkinson's disease, what does that mean therapeutically? And that leads to sort of disease subtypes, which I'm going to talk about. Then I really want to concentrate on the technologies, which are a bit tedious, you might think, but the technologies we can now apply to individual patients means we can really start to understand the disease on an individual basis. So you can start to see that in the future, people love this idea of personalised medicine. You turn up, we can do things with you, and we could put a therapy into you, knowing it would work for you because we can test everything about you in the lab. And then that is where I will end up about new approaches and new theories, including my current pet theory on what I think might go wrong in Parkinson's with its therapeutic implications. So let's start with the definition of Parkinson's disease itself. So as many of you will know, then Parkinson's disease takes its name from James Parkinson, who described it in 1817. He called it the shaking palsy. It was Charcot who called it Parkinson's. And what is still extraordinary in 2025 is that diagnosis of Parkinson's disease in the clinic is made by somebody saying, I think that's what you got. And so people find that very strange. You know, if you turn up with chest pain and you think, well, is it related to your heart? I'll stick you on a treadmill. I can do all sorts of fancy stuff. And I say, your chest pain is definitely due to your coronary arteries because I can show that when you exercise, your heart doesn't get enough blood and you get the pain and your ECG changes. Parkinson's disease, you still say, I think that's what you've got. And before, really, only the latter part of the 20th century, that was it. It was just, Simon says you've got Parkinson's. You've got Parkinson's. There weren't any criteria. Well, what actually came out in the very end of the 20th century were the Queen's Square Brain Bank criteria. So all of our original studies, which were done, were based on this. And this still is the mainstay of how we do it. It's clinical features. So the details aren't important. The point is the diagnosis is made on clinical features. You turn up, that's what you look like. So those were the criteria we used to make the diagnosis. And they remained the mainstay until about a decade ago, when the Movement Disorder Society, which is this society which was set up in the 1980s to bring together researchers, clinicians, on Parkinson's disease, decided to actually set about systematically defining different aspects of the condition. So we had more universal ways in which when I said someone had something, everyone agreed because they used these criteria. So these were their diagnostic criteria. They were essentially, you can't read any of that, but the point of it is it's no different. It's essentially just a bunch of clinical criteria. So you have to have a bit of tremor, bit of stiffness, bit of slowness. And then what they said was there had to be things you couldn't have. So things that made you suspect someone might not have straightforward Parkinson's disease, but one of these more complicated forms of it. So they slightly elaborated on it, but in 2015, that's still what it was. What do you look like? That's what you look like. That will do. Then it was thought that the problem with diagnosing Parkinson's disease is not just the criteria, but one of the biggest challenges is when people first present. So typically when you present, you can sort of say, I think someone's got Parkinson's because we use these criteria, but actually it can be quite subtle. And you sort of think, well, perhaps they've got a bad day, perhaps I'm having a bad day. You know, is it really the case? And obviously when you see someone who's had the condition for 5 or 10 years, they've been on treatment, it's much more obvious. But as Simon was saying, the challenge will be, and the place where people are heading, is to treat people early. So if you want to stop something, stop it early. Well, if you can't be certain when people present, that makes it even harder. So there were some very famous studies done at the turn of the century where they were looking at various drugs to slow down and treat Parkinson's. And 10% of the people who presented with Parkinson's, as diagnosed by experts, turned out not to have Parkinson's. So that instantly makes it difficult to do a trial, because 1 in 10 of your patients ain't going to get better with your disease-modifying therapy because they ain't got the condition that you think they've got. So these new criteria were then applied to newly diagnosed patients, and they were actually pretty good. So actually you could improve on people with early Parkinson's disease if you took into account all of these other criteria. But the point here is it's still all clinical. So it's all based on what you see. And this is a bit of a problem, and I'll come to talk about how people have tried to resolve this. It also became clear, and so this again is something which we now take for granted, but when Simon first started doing, we started doing research together, the idea that Parkinson's had something before you presented was a little unclear. It was always suspected because by the time you present with Parkinson's clinically, you have these dopamine cells in the bottom of your brain, you have about 500,000, you lose half of them, then you get the first motor features of Parkinson's disease. So what did it look like when you lost a quarter of those cells? So there was always this question, was there anything that was evident before you ever turned up with your tremor, your stiffness, your slowness, this so-called pre-Parkinson's? And actually, that became much more obvious with this idea of prodromal Parkinson's, which Simon touched upon. So these are the features which you have before you develop overt disease. And so whilst people were always curious about this, no one could really tie them down. There were all sorts of questions about personalities. There was a study which said constipation seemed to predispose to you getting Parkinson's, but was it predisposing or was it actually just the earliest feature? So the Honolulu Heart study showed that. So then, at around the same time as Parkinson's disease was formally diagnosed by the MDS with their new criteria, the prodromal features of Parkinson's disease came up. And this was, exactly as Simon was saying, this consisted of a number of features which people had before they developed Parkinson's disease. So this instantly had an impact in the clinic, because when you see people for the very first time, you think, I don't know, have they got Parkinson's disease? Can't quite be certain. Then you can say, what's happened to your sense of smell? What's happened to your sleep? Well, often the people themselves have no idea what's happened to the sleep, but the other person who's come with them can tell them about their sleep. And as Simon says, if you have an absence of smell, constipation, and you're acting out your dreams, your chances of getting Parkinson's disease or something like it is dramatically increased. There's a paper that's just come out from a big study in Italy, which is with thousands of men. I don't quite know what the original study was, but in those patients, 100 or so of them have now gone on to get Parkinson's disease. In those patients, if they had a lack of smell, acting out their dreams, a bit of constipation, your chance, you just had those three features at baseline, your chance of getting Parkinson's went up 26-fold. So these are occurring before you get Parkinson's. So this is what goes wrong before you develop the overt disease. The problem is they go wrong, but then the question is, are you going to get Parkinson's or something like it? Are you going to get that next year, or is it going to be in 10 years? And that makes it difficult when you're trying to think, well, if I use this to bring people into a study, how can I give a drug to show it's going to stop them getting the disease if they might not get it for 10 years? So that creates a problem, but it nevertheless raises this. So now you can use it in clinic to ask people, and that can help you. The problem with it is very non-specific. So if you just say to people in clinic, do you have a problem with your sense of smell, your bowel, your mood and sleep? Every single person will say yes. They'll have something wrong in all of those. So it's not that discriminating, but in the right hands, and as you can hear from Simon's research, as you start to tie it down, it really helps. So now, over the course of this century, we've gone from a rather vague definition of Parkinson's disease to something that's much tighter. It's been shown to work in early stage Parkinson's disease, and now we have criteria for diagnosing people who are at risk of getting Parkinson's because we think they're in this prodromal stage. But it's all clinical. It's all what you say. It's what we do when we test people. Is there a better way of doing it? Well, people have been very keen on trying to find markers which show you've got Parkinson's. So there are a few very common questions in clinic. One is, have you got a test that can prove I've got Parkinson's? They say, can't you do a scan? Well, I can do a scan and show you haven't got dopamine in your brain, and that would, a DAT scan, which would fit with Parkinson's, but it's not specific. There are other conditions that can do that. Is there a blood test? Well, no. Is there some other clever test you can do? Well, no. So none of these have been proven to be helpful. But in the last 2 years, people have got very excited about this new test which has come along, which is called this alpha-synuclein, which is the protein at the heart of Parkinson's, seed amplification. So this is not a new idea. So this idea is essentially that you take some fluid from somebody and you find a seed within it. So this has its origins in mad cow disease, prion disease. This is how they used it to be certain people have got mad cow disease. But essentially what you do is you take a bit of fluid, and the seed, in this case, is alpha-synuclein. So we think the alpha-synuclein is abnormal in Parkinson's, but it's there in very low amounts. So I can't really measure it with great accuracy. So then you can amplify it, and as you amplify it up, you can then start to see, is it there, and then is it aggregating? And so this is a way of trying to develop a blood test or test from the CSF, which could help you diagnose the condition. So this work, which was taken on really by the Fox Foundation, has been shown to be very sensitive and specific. So in people who you suspect have Parkinson's, if you do this test in the right hands, it seems to be very helpful. So this is proving to be quite an exciting development. Now there are some slight snags with it. Not everyone can get this test to work exactly as advertised. But what it has done is it's led to this idea that we could diagnose Parkinson's in people when they have nothing. So this creates a bit of a sort of a dilemma, but I'll just finish this bit and then put up the dilemma. So the idea here is people are saying we should stop calling this Parkinson's, because that's not very helpful. Parkinson's just describes some symptoms and signs that you have, but actually we should talk about what the real problem here is, and the real problem is this protein alpha-synuclein, and the real problem is the alpha-synuclein gets into cells or is in cells and it misbehaves and causes problems. So we should get rid of the term Parkinson's, and so everyone with Parkinson's is now said to have neuronal alpha-synuclein disease, which I'm personally not a great fan of. But there are people who are very keen on this. So first of all, we get rid of the term, which I'm not sure is helpful. And secondly, the idea is that your diagnosis of neuronal alpha-synuclein disease, so you can't have Parkinson's anymore, you can only have neuronal alpha-synuclein disease, is based on a positive seed assay, regardless of whether you've got anything, and which puts you at risk of having this dopamine loss. So the diagnosis is now based entirely on a blood test. Now, of course, that's not new. So none of you know if you've got high cholesterol. You won't come in and say, Simon, I'm not feeling very well. I think my cholesterol's quite raised, because you won't have anything from it unless you've had a heart attack or a stroke. So blood tests can be helpful, but is this useful? And of course, then it has the implication, well, actually, could we take this out and screen the population? So everyone over the age of 60 will do a blood test and we'll see who's positive. Well, of course, we do screening all the time. I don't know what it's in Australia, but you know, in the UK, do a lot of this for breast cancer, colon cancer. And of course, you do it because you can do something about it. So then the question is, well, if you do this with everybody, and Simon comes on and says, well, I've done your seed assay, Simon, old boy, you're positive. I said, what does that mean? I said, well, you're going to get Parkinson's. You're not going to get Parkinson's, you're going to get neuronal alpha-synuclein disease. You say, what are you going to do about that? And I'm going to say, well, nothing, because I haven't got anything to do. And they'll say, well, what am I supposed to do with my life insurance, my mortgage and everything else? And you'll say, well, I don't know, but that's the test. So, but if you don't do it, then when the therapies come along, how can we start to use it in people at the appropriate time? So it's created quite a discussion, but essentially people have now started to talk about Parkinson's as neuronal alpha-synuclein disease based on a blood test, not clinical features, and you stage it in various different ways. The first stages have nothing to do with anything you complain about. Then you develop subtle problems. And as you can see, it's now quite a far down before you're actually have any physical features which the doctor will tell you means you've got this condition physically. So this is becoming a very hot topic. So this is the sort of classification that people now talk about. Some people are absolutely evangelical about this. They say this is what it should be. We should be talking about this neuronal alpha-synuclein disease. We should be talking about this seed assay. We should get rid of Parkinson's, and we should get rid of the clinical features as being useful in any diagnosis. This is the way forward. And I think it might be helpful on a research front, and I think it might be helpful as a way of reinforcing that you've got people in your trial of the right type. So I can imagine in trials in the future, we will still have to recruit people who've got something wrong with them. They will come in and we say, we think you've got prodromal Parkinson's, or you've got early stage. We're going to do this seed assay, which will help confirm it, and we'll take it from there. But for the moment, I cannot see that this test will become the defining way in which we describe this condition. But that is where the field has moved to in 2025. So if you do any searches on publications in 2025, this is probably top, I would say, of the discussions which happen in the world of Parkinson's. So in 25 years, we've gone from a rather broad clinical description to an argument about whether we should be using clinical features at all to define this disease, and whether we have a blood test which will ultimately prove to allow you to make the diagnosis. So this is an exciting point in the evolution of our work in Parkinson's. The second is I want to talk about epidemiological and genetic studies. So epidemiological work is where you essentially try and work out, go out into the population and find out about this condition. So when I first started setting up my research group in the late 90s in Cambridge, we thought, well, let's see what's out there. We thought we might do an epidemiological study, so let's see what everyone else has found on the epidemiological studies. So in 2000, there were none. So nobody knew how common Parkinson's was. They didn't know the basic facts about it. What was the average age you get it? What's your life expectancy? Anything like that. So it's extraordinary to think that we didn't know that information, because most of the information you get on how common things are is based on people coming to clinic. And one of the factors, an interesting aspect on epidemiology, for example, is Alzheimer's disease, incidence of Alzheimer's disease. So if you're now 70 or 75, the chances of you having Alzheimer's disease at 70, 75 is much less now than 50 years ago. So if you're 70, 75, the incidence of Alzheimer's was much higher because your lifestyle is much better. So then the question is, but why are people always banging on about Alzheimer's disease being such a common problem? It's because 50 years ago, not that many people made it to 70 to 75, whereas now most people do. So the prevalence, the number of people goes up because the population ages, and that is true of Parkinson's. So just the epidemiology, there was none. What about genetics? So what did we know about the genetics of Parkinson's in 2000? What we knew was that alpha-synuclein had been discovered in a family in Parkinson's in 1997, and then alpha-synuclein association with Parkinson's was in 1998. So just over 25 years ago, alpha-synuclein was linked to Parkinson's. Prior to that, it had nothing to do with it. So that's been a big change. And also, there were some very young patients who got it with a very rare mutation in this gene called Parkin. So there were two genes which were thought to be related to getting a form of Parkinson's. There was no knowledge about how Parkinson's behaved in the community. And was it inherited? Was there anything in the family? No real idea. David Byrne had done some scanning in people with twins and shown that the unaffected twin might have a slight change in their dopamine compared to the twin who had Parkinson's. So there may be some genetics. But the general feeling in 2000 was genes had nothing to do with Parkinson's, and we didn't really know much about how it behaved normally. So we set about trying to answer the first of these with the epidemiology. So we set up this study called the campaign study, where we collected everyone with Parkinson's within the county of Cambridgeshire in the east of England over a 2-year period. And then we followed these people over time. So we followed them up, and we followed them up to the present day. So I think we now have, there are 159 patients who are recruited. I think we're now got 12 people left in our study 25 years after that. You think, well, that sounds pretty grim. But actually, we had some interesting facts about Parkinson's. So in Cambridgeshire, every 5 days there's a new case diagnosed. So this is a common condition. It's as common as multiple sclerosis. So it's one of the commonest neurological conditions. The average age you get Parkinson's is 70, whereas the Americans always said it was 59. But the average age you get is 70, and we've repeated the study, and it's 70, and a group in Scotland have done it, and it's 70. So that's the average age you get it. It doesn't shorten your life expectancy. So if you follow people in the community and collect death certificates, then first of all, the number of people who die with Parkinson's as their primary indication is about 10%. So most people die with it, not of it. And if you look at people who've got Parkinson's versus people who've not, then actually there's no difference in the death rate in terms of life expectancy. And you sort of say, well, why are only 12 people left then? Well, the average age of our cohort is now 95. So that's why there aren't many people left. The one thing it does do is it does increase your risk for dementia, as Simon's been talking about. So if you have Parkinson's, your chances of getting a dementia go up 2.5-fold. So there's definitely a risk of that. And what we would say is that 40% of people at 10 years have dementia, and not from our own studies, but from a study done here in Sydney, 80% at 20 years. So this is a major problem that we've yet to unravel. But that's the basic facts about Parkinson's. So now we can say, in 25 years' time, if we repeat this study, has the age changed? Has life expectancy? We can start to understand what's happening about this at the population level, which is what the governments are very keen to know about. We also took other approaches. So there was a young Dr. Lewis. I don't ever know what happened to him, but he thought he'd probably never get on with research and Parkinson's. But he did this study, which was a sort of seminal study where we not only tried to understand the basic facts about Parkinson's, but everybody who came to our clinic, we sort of plugged them into some early analysis in those days, principal component analysis, to try and work out subtypes. So this was the first attempt to try and say, we can diagnose Parkinson's. This was based on clinical criteria. People behave differently. Can we work out whether there are different subtypes? And if there are different subtypes, what do they look like? And that may have some implications for therapeutics. And then in order to sort of validate, so Simon came up with various different subtypes, which have subsequently been shown, I think, to be largely true. And then in order to show that this isn't just an odd study that we did, we repeated our study, the iSchool study on the campaign study, and showed exactly the same demographics, same incidence, same average age, and we're still following these patients up. So this was the first work that showed how common it was, Parkinson's, and some of the basic facts about it. And then the theory of the work was we had no theory. So we did everything you're not supposed to do in science. We had absolutely no hypothesis. We just collected everybody, and we'll follow them over time. And our argument was, which is why Simon did his sort of data analysis on a group of patients, if we follow our patients from the moment they're diagnosed, where do they end up? And what we found was that people ended up in different places, as you would expect. And then the question is, well, where do they end up and why? So what we discovered was that there were various different types of thinking problems in Parkinson's. There were different types of inflammation in the blood, which were predictive of where people went. So this is all at baseline. So when you pitch up in your clinic, there are 3 things that we discovered. One was your thinking test. One was if we did a blood test to look for inflammation, and the other was your degree of constipation. So basically, if you were not very good at drawing these interlocking pentagons, couldn't come up with long lists of animals, were over 72, you were in trouble with your Parkinson's, because that was a bad outcome. If you had more inflammation in your blood based on simple measures, that was a bad prognostic factor. And if you had a lot of constipation, that again was predictive of not doing so well. So now we were starting to have useful measures at the time when people came, not only where they had Parkinson's, but where they were going to go. And so this allowed us to have these 2 types. One were people who had some subtle thinking problems. So you can have thinking problems with Parkinson's which have nothing to do with anything going badly wrong later on. And actually, these patients who were younger could do all their cognitive tests, had no constipation. Often they were taking, and we've never really tied this down, they're taking aspirin, Brufen and all of these things for joint pains. These patients seem to do better. By which I mean that 10 years in, a lot of these patients were still walking around, had no thinking problems, living life independently. Conversely, older patients, so people over the age of 72 when they first presented, who couldn't do these animal lists and these interlocking pentagons, who had measures of inflammation in their blood, not huge levels, but increased levels, and were more constipated, they had a much higher risk of getting a dementia. And so then we started to say, well, why is this? And there were two ways in which we approached this. One was we tried to look at the genetics. Were there genes which made you more likely to do less well? And there are a few up there. And then we tried to model it in the lab, which I will come on to. So these original studies were very helpful because they really have set in place the idea that Parkinson's is not one condition. There are several different types. And we can now start to predict where people are going to go. And that's going to influence how we do drug treatments. What about the genetics of Parkinson's? So in 2000, I told you there were basically these two genes, and it wasn't thought to be genetic. We thought, well, let's be very clever. So we went to a company in Iceland and said, let's look at the whole of the DNA of patients and compare the DNA of patients against people who don't have it and see whether there are more genes in people with Parkinson's which might be associated with it than those that were not. And we found absolutely zilch. So we found nothing which fit in with what everyone had said. So we took 195 patients, then we tried it again in 180 patients, and we used 5,500 markers across the whole of the DNA. So you think, well, that's pretty impressive. But you could sort of stop at that point. But what people did said, I don't think this is powered enough. So people have carried on with this type of approach. And in 2019, these are all of the genes which are associated with the risk of getting Parkinson's. So from our study where we showed nothing, there's now over 100 different gene variants which increase your risk of Parkinson's, and that's based on 38,000 cases, and now they've gone across the whole DNA with nearly 8 million markers. So it puts us in our place, really. I mean, 350 and 5,500. I thought we were pretty crackerjack, but actually, clearly, we were completely nowhere. So the technologies for this have exploded. So now we have in people who have apparently sporadic disease, vast numbers of genes which are associated with the risk of getting it. So then, coming back to the work we did where we said, why do people develop an early dementia? Is it to do with the genes? Well, we'd done it in our study and we came up with those various genes. So now these bigger studies pressed on. So this was one which said, well, look, there are these three genes here which are associated with a risk of getting dementia. So these very clever, powerful techniques show that. And then another study did it and said, great, we've done exactly the same and we don't find any of the same as you. So these new technologies, both of these very big studies, have come up with three genes which are associated with early dementia, and there is no overlap between the two of those two studies. So one may be right, the other's wrong. They may be both right, or they may be both wrong. But at least the techniques are there now to start to address these questions. The other thing that's happened is, I already said there were some genes which were associated with Parkinson's in 2000. During the next 25 years, large numbers of genes have been associated with it, which I'll come on to briefly talk about. But the one gene which has become very mainstream is this gene called GBA. So GBA is quite a rare gene. Most people had never heard of it prior to the last 15 years. So if you get two abnormal genes on this, you get a very rare condition called Gaucher's disease, which is normally a childhood disease, big spleens and problems of that nature. But it was noted by Ellen Sadransky that families who had Gaucher's disease, that quite a lot of the relatives had Parkinson's. Seemed a bit unusual. No one really believed her. Didn't come out of any of these genetic studies. But then people started looking specifically for this gene in people with Parkinson's. And actually, in 100 people with so-called sporadic Parkinson's, about 10% will have an abnormal gene for GBA in one of the two genes they have for it. So this is the commonest genetic abnormality in Parkinson's, 1 in 10. So in this room, I don't know how many people are in here, but probably a number of people in this room will have this gene variant. And people with it tend to do slightly less well with Parkinson's. They tend to progress more quickly. So when we went back and looked at all of the patients we'd collected in our campaign study and our iSchool study, we showed that people who had this gene progressed more quickly during the course of disease. So this is definitely a gene which, if you have it, tends to push things quicker. So it gives you some insight into the fact that whatever this is doing is somehow speeding up the disease process in this group of patients. And so finally, for this bit of the talk, I just want to highlight that in the last 25 years, we've now got a series of genes which we know underlie certain forms of Parkinson's. They tend to be rare apart from the GBA one. So they're these rare families who have alpha-synuclein abnormalities, but people with Parkinson's all have alpha-synuclein pathology. I've talked about GBA, but people are now going after this therapeutically. So people who carry this mutation, perhaps we should selectively treat them with ambroxol. You could use it with everyone with Parkinson's. People are now using gene therapy to replace this enzyme in people with Parkinson's who have this abnormality. There's another gene called LRRK2, which came out in the early noughties, and now there's a whole series of clinical trials designed to treat people with that form of Parkinson's. And this rare Parkin that I mentioned right at the beginning in young people is the subject of 3 trials, including a gene therapy trial. So this is now becoming much more the norm. We're not only diagnosing Parkinson's in a different way, we're saying there are different types of Parkinson's disease and there are certain genetic forms, and that's having an impact on how we treat it. I now briefly want to talk about the technological advances that have taken place, which allows you to sort of take things apart. And I'll try and get a bit quicker because I think I've slightly lost track of time, to be honest. So in the last 25 years, our ability to model Parkinson's and to understand what goes wrong in people has transformed. So this chap, Jamie Thompson, in 1998 was the first person to, hang on, Simon told me about my shoelace and now it's come undone. So he was the first person to take human embryonic stem cells. So when you fertilize an egg, you form a blastocyst. The blastocyst gives rise to the early embryo. And all of us at one point in our life were a blastocyst. But it was discovered in the 1980s, but in mice, but in the 1990s it was shown that you could take some of the cells out of this very early fertilized egg, so-called embryonic stem cells that turn into every cell in your body, and you could grow these in the lab. So suddenly you could take human cells and grow them into any cell of the body, and you could turn them into dopamine cells. That was discovered in 2011, 2012. So now we could take embryonic stem cells, human, and turn them into any cell in the body and study those cells. So we could study human nerve cells in the dish for the first time. Then in 2007, Shinya Yamanaka in Kyoto discovered that if you took adult cells, so skin cells or blood cells, you could persuade those to become like an embryonic stem cell. So you could reprogram them back to a cell which could turn into any cell of your body. So suddenly you had the potential, in the case of Parkinson's, is we can take people with Parkinson's, take a bit of skin, take some blood cells, so these are adult cells, turn those cells into induced pluripotent stem cells, and then turn them into dopamine cells, or any cells we like. So that has 2 possibilities. One is we could start treating you by replacing the cells you've lost through your own cells, but also you could start to study what went wrong in people's dopamine cells in Parkinson's by taking cells from them and studying them in the dish. Then in 2009, Hans Clevers developed this technique where you don't just grow the cells in a dish, but you turn them into little blobs, little organoids. And then this was taken on and shown you could make little brains. So now what you do is you take stem cells, you grow them in a rotating dish, and they make little complex structures. So you can make new midbrains, which is where the dopamine cells, you can make bits of the outer part of the brain, the cortex. So you can now start to make 3-dimensional models in the dish of cells from patients with diseases. So this opened up huge potential. And then one thing we were particularly interested in was trying to look at taking skin cells, and rather than turning them into young cells, iPS cells, then turning into nerve cells, we wanted to turn them directly into nerve cells. The advantage of that is you can retain age. So when you take skin cells and turn them into iPS cells, you make them very, very young, because obviously that's where they began. And the biggest risk factor for Parkinson's disease is age. So we wanted to keep age by directly converting skin cells into nerve cells, and these are called induced neurons. So over the period of about 15 years, we suddenly had the capacity to grow all sorts of cells and structures from patients, which opened up all sorts of possibilities. So we did a study where we took lots of patients with Parkinson's, sporadic Parkinson's. We took skin, we turned them into nerve cells, and then we studied them. And we could see that there were clearly problems in the Parkinson neurons which were not there in people who didn't have Parkinson's. So that has two implications. One is it tends to imply this may be going wrong in Parkinson's, and this is from cells from people with Parkinson's. And now we're using this in our trials, not in Parkinson's, but in Huntington's disease. We've done exactly the same. We've done a trial with people with Huntington's disease. We've given them a drug which we think targets a pathway, and we've grown cells, taken cells from all those patients, turned them into nerve cells, and studied how the drug behaves in the nerve cells in the dish, and then compare it to how it's behaved in the patient itself. So this has transformed how we think about doing clinical trials. Coupled to this ability to study cells from patients has been this phenomenal explosion of the analysis of cells. So there are now technologies. So typically in the old days, what would happen is you would say, what goes wrong in, let's say, dopamine cells? I'm going to grow a bunch of dopamine cells. I take all of the dopamine cells. I analyze all the dopamine cells from people with Parkinson's versus not, and I see what the difference is between the two. And that gives you some idea. But wouldn't it be nicer to say, well, it might be that actually only 5% of the cells are different? But if I've got all the cells, I'm never going to see that, because that's signals lost, because 95% of the cells are no different. I'm not going to see any different. So what people now can do is they can take individual cells, so individual cells, thousands of cells, and they can analyze each cell to see what it's actually producing. So this thing called single cell transcriptomics. So the idea is you can take, for example, we've just done some studies, you take 30,000 cells and you study what's coded in each of those cells, 8,000 genes in a single cell. So suddenly you can now look at these cells in incredible detail. So here is a paper just to illustrate this. They took cells from patients with Parkinson's. They then took people who behaved slightly different with their Parkinson's. They made iPS cells. They turned them into dopamine cells. They did single cell analysis and said there are differences in this population of cells, in these people who have Parkinson's, and this is the problem. So you can start to not only understand what goes wrong, but in which cell and exactly what's wrong. And this has now expanded to include the brain. So this is work which has only just really been possible in the last 5 years, I would say. So now what we do is we take, and I'm sure this is being done here in Sydney, is we take brains, so people who've died of Parkinson's, we now look at individual cells from those patients and we say what's gone wrong. Now there are some problems with this. Part of the problem is, of course, the cells you're most interested in have gone because the person's lost them as part of their disease process. So you really want to know what the problem is with the cell's gone. But you can now look at individual cells in the human post-mortem brain to know what's wrong with them. And not only that, you can now plot this. So this is a patient who died of Parkinson's. This is a bit of the brain where the dopamine fibers innervate, and every single one of those dots is in an individual cell expressing genes to do with inflammation. So you can see that there is inflammation in the brain in Parkinson's, but there are certain areas where there isn't. So why is that? So you can now really start to take things apart. And then the other thing which has really transformed the field, so not only do we now have the technologies to take brains and cells apart in individual patients, but the other thing which has really transformed what we can do is some of the other modelling. So about 20 years ago, it was shown that in people who'd had transplants of young dopamine cells into the brain, some of those dopamine cells had acquired the pathology of Parkinson's. Well, that's a bit odd because they're young dopamine cells. I put them into the brain of someone with Parkinson's to replace them. So why have they developed Parkinson's in their brains in the cells which are so young? Because you don't see Parkinson's in people who are 20. So the theory was that the reason these cells, which had been transplanted into the brain, these young cells, was because the alpha-synuclein, this pathology you see in Parkinson's, had spread and infected your transplanted cells. So the idea was that alpha-synuclein had spread from the Parkinson's brain into the new young dopamine cells. It then combined with alpha-synuclein in the dopamine cells. They fed off each other and they caused the pathology. In other words, Parkinson's was part of the problem was the pathology spread. So once one cell's got it, it can pass it to another cell and pass it to another cell. So in terms of modelling, this transformed what you could do. So we had a study where we injected alpha-synuclein into the circulation. We connected it to a particular protein so it could get into the brain. And what we found over time was that these rats which had had this injection developed all the pathology of early Parkinson's. So their gut got affected, their smell got affected, their dopamine cells got affected, other bits of the brain. So we now had a model which would enable us also to look at new treatments. So finally, I'm just going to talk about two things very quickly. What has this meant for therapeutics? So what has all this technology taught us? So what it's done is it's allowed us now to put together some sort of map of what may be going wrong. So there are genetic predispositions. Alpha-synuclein is involved. It may spread. It causes inflammation. And this then all leads to problems. But the disease process probably begins 10, 15 years before anyone ever presents. So what has this meant therapeutically? So people have said, why don't we switch off alpha-synuclein? So people are trying to do that with various clever ways. There's a lot of interest in asthma drugs around this, beta agonists, the Ventolin inhalers, that they may have some role you could use in that. So people are investigating that. Could we stop the spread of alpha-synuclein? So people are now developing vaccines. So lots of trials with vaccines to try and stop the spread. Could we stop the cells from dying by using drugs which are already out there, which Simon was briefly mentioning along with gene therapies? Could we stop inflammation? Can we replace the lost dopamine cells with transplants? Can we rescue those that are there with fertilizer and growth factors? And can we use some of the systems there better? So there's a lot of therapeutic implications which have come out of all of this knowledge. The other thing is it opens up new possibilities in terms of theories. So we have this project we're exploring at the moment, which is that as you get older, a lot of your DNA contains ancient viral infections, which was put in hundreds of thousands of years ago. And what we think, these are called transposable elements, and what we think happens is as you get older in Parkinson's, some of these bits of DNA get re-expressed. The brain thinks, what's that DNA coding for? Well, that's an old viral infection. Well, it's a viral infection, I'm going to kill it off. So it then produces an inflammatory response to get rid of that viral infection. That's mainly with a thing called interferon, which actually increases more of these expression of these transposable elements. So the idea is you get older, transposable elements get more expressed, causes an immune response, and that drives this whole process, and that's what drives what goes wrong in Parkinson's. So it's a completely new theory. We've got quite a lot of evidence to say that it's true. It also has therapeutic implications because we could obviously target inflammation, and these transposable elements work on a principle similar to AIDS in terms of how they get re-expressed. So could we use AIDS drugs to switch off what might be going wrong in Parkinson's? Completely new theory. We wouldn't have been able to do this without the technologies and the other information we've had. So to conclude, I think there's been a major change in how we understand Parkinson's. We're going earlier and earlier in the disease course. I still think we need to diagnose Parkinson's based on what we see in front of us, not just on a blood test. I think the blood test will be helpful, but I don't think it will replace what we do clinically. I think it's clear that we now better understand the natural history of Parkinson's. We understand the subtypes, and we're starting to understand the basis for that, which means that therapies will become much more given in certain groups of patients rather than with everybody. I think we've now got huge numbers of very powerful techniques which will absolutely blow apart what we know about this condition in a way which I don't think we could even conceive of 10 years ago. And that, as I said right at the beginning, all of this has meant that the therapeutic landscape in Parkinson's is transformed from what it was 25 years ago. So when I first came to Cambridge with my group in 1997, there were essentially possibly 2 or 3 trials going on around dopamine drugs in Parkinson's. That was probably it. Now there are trials, I don't know how many trials going on with Parkinson's. So this has transformed, the landscape has been transformed, and it's not just better dopamine drugs. As you can see, there are huge attempts now to try and target all aspects of the disease, which are changing every year as we learn more about it. And finally, lots and lots of people who've done all of the work over the years, a lot of which I haven't talked about, and the funders who've been kind enough to support us. And I've spoken for far too long, as I always do. So sorry about that.